Pharmacologic management of pain. This is a relatively short lecture this week, so yay, we all get a little bit of a break. Also, very important one though, especially, good grief, since pain and opiates in particular is the hot topic of this particular year. You certainly want to understand how everything works, both the opiates and the alternatives. There's a lot of specialty stuff in pain management, and I'm not going there just because, number one, I don't know that much about it, but it's very individualized and really kind of subjective. What I'm talking about here in this slide set is the stuff that everybody acknowledges is the approach to pain management on the day-to-day basis as we know it. Some specialty things like migraine management, injection steroid management. Oh, I can't think of anything else right now, but there are lots of little specialty niches, and then there's there's just other stuff. But what we're starting with here is the foundation. So that's the point, and it always starts with the physiology. So the physiology of pain is also kind of a specialty area, and there's lots of things that not everybody agrees on, but there is a core foundational, clearly understood pathophysiology of pain, and that's what I want to take just a minute to review here. Well, I always say just a minute, and then it's a little more, but not much. Let's see, advance. Oh, okay, yeah, physiology of pain. All right, so this is the stuff that everybody agrees happens. You receive a stimulus. The stimulus may be from outside. It may start outside of your skin, and the initial introduction is by pain sensations in your skin, by nociceptors. Those are pain receptors in your skin, or it may start internally, and nociceptors are triggered from within, like if you are having an MI or a perforated organ or an inflamed organ or labor or something like that. Wherever it starts, the very first thing that happened is whatever the stimulus is, it has to be converted into a nerve impulse, and that is called transduction, and that is the initial point of contact with the stimulus. The most peripheral nerve that receives it, and it's typically a nociceptor, transduces it into a neural impulse. That impulse then has to be transmitted to the brain. It has to be carried to the brain, and that is called transmission. It's not pain if your brain doesn't feel it. It's like, what is that old saying? If a tree falls down in the woods and nobody's there to hear it, does it make any sound? That is a philosophical phenomenon, since sound actually is what is perceived by your ear, right? Based on the wave of air. So anyways, I don't know, I'm not that philosophical, but I can say that we generally don't refer to it as pain if the brain doesn't perceive it. Many of you have experienced this by way of a peripheral block. If you've ever had a finger sutured, a toenail removed, a cavity drilled, you get injected with a local anesthetic. And after that anesthetic, that blocks transmission of the impulse to the brain. Believe me, there is still a stimulus, whether it's a drill in your tooth or a needle in your finger or whatever. You still have a stimulus that is transduced to an impulse, but that impulse is not transmitted to the brain because there is a block, a local block in the way. So it has to be transduced, then transmitted, then your brain has to perceive it. Your brain has to perceive the impulse, and there are things that influence perception, and we'll talk about them a little bit later in the slide set. And then finally, your brain, the receptive center, does have the ability to modulate. Your brain is always making chemicals that would attenuate pain, that will modulate. Yeah, I said that right, the way it is perceived. So all of these conspire to produce the pain sensation as any given patient feels it. And of course, the first thing you always hear in the discussion of pain is that it is very subjective, that it's each individual's experience. Two identical stimuli may produce very different pain experiences in different people, and it's not that one is too stoic or one is too exaggerated. It's just that all of these factors conspire to produce the pain experience: transduction, transmission, perception, and modulation. It's funny, like in the classroom, we all say about how pain is the individualized experience, and we have to take the patient's word on whatever that pain may be, because everybody perceives it differently and modulates it differently. And then in real life, when somebody says they have pain and they're like sitting there breaking a sweat with a heart rate of 150, we're like, drug seeker, which is totally inappropriate. It really is totally inappropriate. I'm not saying that you won't come across drug seekers, but you've got to base that on more than the physiologic phenomenon, because, well, we'll talk about it a little bit later. But anyways, these are the aspects of the physiology of pain that everybody agrees occurs. And that's why the experience is different for, any two people with identical stimuli. All right, so we have two general types of pain receptors. These are the nociceptors. These are the receivers that transduce that impulse, that stimulus, into a neural impulse. We have fast pain receptors and slow pain receptors because they have different roles in the body. Fast pain receptors' job, as you might have deduced, is to get the sensation of pain, get the message of pain to the brain fast. The job of God bless America. The job of fast pain receptors, say that 3 times fast. The job of fast pain receptors is to notify your brain immediately that some part of your body is being damaged and to remove it from the damaging stimulus immediately. So the message has to get there fast. It's not going to do any good if it takes too long to get there, because then whatever body part it is destroyed. So fast pain receptors, they get the message to the brain within 0.1 second of the stimulus. The pain is felt distinctly as sharp, acute. People will describe it as electorate. It's usually like very localized and very specific. They know exactly where they're feeling the abnormality. This is more of a superficial pain in general. Now, there are exceptions to every rule, of course, and there are some fast pain receptors and deeper in the body, but they're not distributed there nearly as liberally. Most fast pain receptors are located more superficially because that's where they can do the most good. Because again, remember, their job is to notify your brain that some part of your body is being injured so that you can remove that body part from the injurious source. If the source is internal, you can't remove it. So it's not as imperative to notify your brain quickly. I mean, if you're having an MI, it's not like you can remove your heart from the source of the injury. So it's not imperative that your brain find out you're having an MI within 0.1 seconds. Whereas on the other hand, if you slam your finger in a door, it is imperative that your brain know right away that your finger is stuck in a door, so you can open the door and pull it out. So fast pain receptors do tend to be more superficial. Their job is to notify the brain there's a problem, get out of there. And it is associated with tissue destruction. Fast pain receptors are triggered when tissue is broken. Slow pain receptors are a little bit different. The slow pain receptors don't get the message to the brain quite as fast. I mean, they get it there, but not quite as fast. Whereas fast pain receptors get the message to the brain within 0.1 seconds. Slow pain receptors, it may take more than 1 whole second. It may not seem like all that long to you, but if your finger is stuck in a door, the difference between 0.1 second and 1 full second can be a lifetime in terms of tissue destruction and further damage. So the differences in these time frames are important to the body. They're not as easy for us to appreciate. So anyways, slow pain receptors, the message does take longer, and this usually is a building pain. It will build up over a period of time. It's a different kind of pain. This is more of a burning, throbbing. This is more inclined to make people feel nauseous, a vagal response to pain. And this is also associated with tissue destruction. The job of slow pain receptors isn't quite the same as fast pain receptors. With fast pain receptors, like I said, the job is to notify your brain that some part of your body is being injured, get it out of there right away. Slow pain receptors, it's more about making sure your body knows that there is some damage and to rest that area. Don't stimulate it. Don't overuse it. So like if you're having an MI, your brain doesn't have to know in 0.1 seconds, but it's a good idea for your brain to know within a second or two that you're having an MI, because then what you need to do is rest. You need to lay down, not have any cardiac strain. I mean, you need to call 911, or somebody need to call 911, but you need to be not active. You need to be not doing anything that will increase myocardial O2 demand. If you are having the pain, if you're having an MI, and then you become more physically active, it's going to hurt more. It's like telling your brain, okay, this part of the body is suffering injury. Just lay down, relax, put minimal workload on it until we can get it fixed. So slow pain receptors have a different role. Many tissues have both. Like if you bang your finger in that door, and again, forgive me if I'm repeating the same examples from other classes, but that's just what I do. If you smash your finger in a door, fast pain receptors right away are going to tell your brain, yo, your finger's smashed in the door, open the door and get it out. And you will. And then you'll pull your finger out and you'll sit there and stare at it for a minute. And you'll think, oh man, that's going to really hurt pretty soon. And then the slow pain receptors do start to kick in. And as slow pain receptors kick in, you will develop more of like a slow, burning, aching discomfort in that finger. And it's going to be worse later on tonight. And it's going to be there for a few days. And every time you try to use that finger, it's going to hurt. Why? Because those are slow pain receptors telling you, hey, damaged tissue here, slow down, give it a chance to heal. Stop taking Motrin and then using it. Just give it a chance to heal, and then when it gets better, we'll stop hurting and you can use it again. That's what slow pain receptors are for. All pain receptors are free nerve endings. They're the thing that transduce the stimulus to a neural impulse. And again, they're very widespread in parts of the body where you can do something about it. They do tend to be more sparsely supplied in deeper tissues, like in viscera, like organs. You don't have as many pain receptors. They're kind of scattered about, and then they feed into like bigger branches that are conducted back to the central nervous system. It's why the sensation of pain in your viscera isn't nearly as defined. Like, when patients are having an MI, their pain, they may not be able to localize it any more specifically than the left side or the left side of the chest or the left arm or the left neck or the jaw or, whatever. If someone is having appendicitis, especially in the beginning, it's very poorly localized. It's like the patient who's having appendicitis never walks in and says, hello, I'm having pain right here in the right lower quadrant. When they first show up, it tends to be more generalized, epigastric, and then over a period of many, many hours, it will start to like slowly migrate to the right lower area. It may be the lower quadrant, it may be the testicle or the labia or something like that. It's just not nearly as defined, whereas in those more superficial areas, pain receptors are widely distributed and you can much more likely localize pain in a specific area. The types of stimuli are listed here. There are 3 general things that will cause you pain: mechanical, thermal, and chemical. Mechanical is, drop something on your finger or your toe and it's going to hurt. Thermal, obviously, extremes of temperature. And chemical are the chemicals that are released from tissue when it is injured. So again, if you smash that finger in the door or you get myocardial necrosis or anything, anywhere, cells will break apart and intracellular contents will leak out into the surrounding environment, and they're the chemicals that trigger that are transduced by these nociceptors. Here you go. These are what's released from the intracellular environment when tissue is injured. Bradykinin, serotonin, I know, I don't have to read them to you. And some of these I know that like the intracellular potassium environment is much higher than the extracellular potassium environment. Acid, remember the intracellular pH is 7.0, whereas the extracellular pH is 7.4. Like if we had a pH of 7.0, we'd be almost dead. So lots of stuff is different inside the cell. It's in different concentrations, and they are released when tissue is damaged, and these things stimulate those free nerve endings. Generally, mechanical and thermal stimuli more likely trigger fast pain receptors, and these chemical stimuli stimulate slow pain receptors. And this is the process of transduction. So whether it's mechanical thermal, or chemical. It stimulates the nerve ending toward the left of this graphic as you look at it, and it is transduced into a nerve impulse by the cell body. Notice that this direction is unipolar. These are sensory neurons. The impulse goes one way. The nerve endings are dendrites, and they perceive this stimuli. It is transduced in the cell body to a neural impulse and continues a one-way direction. Next step is to be transmitted to the brain. Transmission of pain signals occurs in a unipolar direction also and heads to the central nervous system. Although all pain receptors are free nerve endings, that's not a real sentence, is it? Although all pain receptors are free nerve endings, comma, the nerve endings utilize two separate pathways for transmitting the signal to the central nervous system. There's two pathways, the neospinothalamic pathway and the paleospinothalamic pathway. The neospinothalamic pathway, the name tells you what it is, new spine to thalamus tract. So new meaning it arose later in embryonic development, which means that the embryo was better developed, more precisely developed when this tract emerged, which means the central nervous system was more advanced in its development. So the neospinothalamic tract, excuse me, neospinothalamic tract has a real precise beginning and end, and it goes from the spine to the thalamus of the brain, and it makes it all the way there. Like this pathway goes from spine to thalamus, and because this pathway arose later in embryonic development, it makes it all the way to the thalamus intact. This becomes important a little bit later on. The neospinothalamic tract is the tract by which type A delta pain fibers make their way to the brain, and type A delta pain fibers are those fast pain fibers. These transmit mechanical and acute thermal pain. You can see how quickly it's transmitted, 6 to 30 meters a second. These are the fast pain receptors. They bundle together in a neospinothalamic tract and they go all the way to the brain. And because it's the neospinothalamic tract, it's a good firm pathway. It goes all the way to the thalamus. The pain impulses get there fast and precisely. Most fibers pass all the way to the thalamus. That allows it to be very precisely localized. Hold that thought. The paleospinothalamic pathway is the other pathway that goes to the brain. The paleospinothalamic pathway, again, the name tells you what it is. Paleo meaning very old. This is the very old spinothalamic pathway. It was it emerged, it developed early in embryonic development when the embryonic nervous system was very immature. So for that reason, it's not as solid a pathway. Most of the tracts, most of the fibers in this pathway don't make it to the thalamus uninterrupted. You'll notice that there's a bullet point here that says the paleospinothalamic pathway terminates widely in the brainstem. This is important for suffering. Yes, if you really want somebody to suffer, you want to transmit pain up the paleospinothalamic pathway because only 10 to 25% of these fibers terminate in the thalamus. So the significance here is that the thalamus is like command central in the brain. When a pain impulse makes it all the way to the thalamus, that impulse can be very precisely localized in the body. So it's important that fast pain receptors, which are transmitted via the neospinothalamic pathway. Remember, fast pain receptors are also type A deltas. Those terms are interchangeable. And the type A deltas bundle in the neospinothalamic pathway and get up to the brain. And because it's the neospinothalamic pathway, almost all of those fibers get all the way up to the thalamus uninterrupted and can be really well localized. The type C fibers are the slow pain fibers, right? They're the ones that are triggered by chemicals. And the type C fibers bundle in the paleospinothalamic pathway to head up to the brain because all impulses have to be transmitted to the brain. Remember, there are steps of pain, the physiology of pain: transduction, transmission, perception, and modulation. Transduction happens by the free nerve endings of the type A fibers for thermal and mechanical pain, and the type C fibers for chemical pain. Then those fibers respectively bundle into the pathways for transmission to the brain. And the fast pain receptors bundle in the neospinothalamic pathway. The slow pain fibers bundle in the paleospinothalamic pathway, headed up to the brain. The difference between these two pathways is the neospinothalamic pathway mostly gets all the way to the thalamus. So the type A fibers, the stimuli in the type A fibers get all the way up to the thalamus. They can be well localized. Type C fibers, that's your chemical pain, that's your slow pain receptors. Because they bundle in the paleospinothalamic pathway, most of them don't get to the thalamus uninterrupted. So the source of pain cannot be nearly as well localized. That's like the big difference between the two. Another significant thing is that these pathways shoot right through the reticular formation. Just anatomically, both the neospinothalamic and paleospinothalamic pathways pass right through the reticular formation. And remember, the reticular formation is an important arousal center in the brain. When your reticular formation or your reticular network is triggered or stimulated, it puts you into a state of arousal. What's interesting is that because slow pain is conducted in the paleospinothalamic pathway, most of which fibers don't make it to the thalamus, lots of them terminate prematurely in the reticular formation. And so slow pain fibers do activate the reticular formation and create a state of hyperarousal. What this translates to is it's very difficult to sleep when you have that kind of pain. When you are subjected to slow pain stimulus, type C fiber stimulus, many of those fibers, their pathway terminates in the reticular formation and it keeps you awake. And any of you who have ever broken a bone or perforated an organ or been in labor or in any way experienced slow pain, which is all of you somewhere along the line, you'll know it's pretty hard to sleep through it. It's very hard to sleep in labor. Most women try to take a nap between contractions. It's almost impossible. I mean, it is impossible to sleep when you are perforating a gut. It's impossible to sleep when you're having an MI. Think about when patients present with acute pain, one of the first things, or with profound pain, I should say, one of the first things we ask them is, did it wake you up? Because if the pain woke you up, then we know it's a slow chronic pain, or a slow pain stimulus, I should say. And that's more likely to be something that we have to pay better attention to. All right, so here's a pretty picture. And I'm going to try to throw in a few labels here just to look at the progression of what's going on. All right, so right here where you see a red one, that's the peripheral most point. Those are your type C fibers and your type A delta fibers, and they're labeled with a C and then a little A delta. And they're picking up stimuli from some peripheral source. We'll just say the skin for the sake of discussion. And the type C fibers were chemically stimulated by the products of tissue destruction, and the type A delta fibers were triggered by mechanical or thermal stimuli, and those stimuli were transduced into an impulse that now has to go through the spinal cord up to the brain, right? So it's moving in the direction of, we'll put a 2 here, it's going to move in the direction of some of your spinothalamic tracts. They bundle as neospinothalamic fibers and paleospinothalamic fibers, or pathways. So where you see a 3, you can see fast and sharp pain fibers, there's one bundle, and then where you see a 4, which I'm drawing right now, that's where your slow pain fibers come together. So 3 is the neospinothalamic pathway and 4 is the paleospinothalamic pathway, okay? Now coming over to the next picture here, this shows them coming up the central nervous system. So let's do an arrow, forgive my lack of artistic talent here. But where you see the 5 is those numbers 3 and 4 at the spinal cord are coming up now as pain tracks at label 5. And then you can't see it as well here. You'll see it better in the next slide, I believe. But you're coming through the reticular formation, which I'm going to circle. And in the reticular formation, over here in the spinal cord, you'll see little arrows shooting off. That's where your paleo-spinothalamic pathway is beginning to terminate. So you're starting to stimulate the reticular formation with impulses that are transmitted up the paleo-spinothalamic pathway. Conversely, the fast pain fibers, which are via the neo-spinothalamic pathway, they make it all the way up to the thalamus intact. And you can see the thalamus here. And the thalamus is command central, and when the impulse gets all the way to the thalamus, you can localize it really nicely in the brain. The thalamus will direct it to exactly the part of the brain that needs to know there's pain. The next picture blows that part up a little bit better. Yeah, here we go. So see, this is just a different representation of the right side of the last slide that we were looking at. So you see how there's a solid line where you see pain tracks, then shooting up. You're shooting through the reticular formation, and you see both a solid line, and then you see little arrows coming out from either end of it. This fast and slow pain fibers, or the neo-spinothalamic and paleospinal pathway, they look like they're all lumped together here. But what's really happening is the slow pain fibers. Now you see how if you follow the line for slow pain fibers, you get a dashed line. The slow pain fibers start to break apart before they get to the thalamus. That, in fact, well, I was going to try to draw a line, but it's not going to do any good. I think you can see it because it's pretty nicely labeled here. Slow pain fibers, they start to break, the line starts to break apart or dash before the thalamus because that paleo-spinothalamic pathway just isn't as precise. The implication of that is that a lot of these fibers started to terminate in the reticular formation, and then by the time you get up to the thalamus, it's only 10 to 25% of the impulses. Conversely, the fast pain fibers, you can see the line remains solid all the way up into the thalamus. So the impulses carried by those fibers on the neo-spinothalamic pathway make it to the brain intact, and the thalamus can localize them very specifically. And there's a couple things that are significant in that. One is that fast pain doesn't usually wake you up. It doesn't require you to be awake, because the message of fast pain fibers is just some peripheral part of your body is being injured. Remove it from the source of the injury. So if you are asleep and something stimulates just a fast pain fiber, it's not going to wake you up. You're going to reflexively absent yourself from the stimulus. The best example I can give you of this is if you get a bug bite during the night. If you've ever, been at the beach or been like in some buggy place like Florida or I don't know, wherever they have bugs in the water, but it's nice and the windows are open and all these mosquitoes are flying in and out. The next morning you wake up covered with mosquito bites. You didn't know it. They bit you all night long, but you didn't need to wake up. However, if somebody had a nanny cam on you, you'd probably find yourself like all night long moving and smacking and reaching and brushing stuff away. Your fast pain fibers told your brain you have to remove an annoying stimulus, and you went about trying to remove it or get yourself away from it. Your brain just didn't need to wake you up to do it. Now, you may have heard me say this before, but a good way to test this theory is if there's somebody in your world that you sleep with, a significant other or a roommate or whatever, wait until they're asleep and then just get like a toothpick or something and go poke them with it. Not too hard, but just poke them with it. That'll stimulate a fast pain fiber, and you can watch them like swat it away. They'll reach over and swat it away, or like if you poke them in the leg, they'll move their leg to try to get away from it. If you're just walking down the street and like one of those big ugly flies lands on you and bites you, you'll reach down and swat it away before you even know what is going on, right? That's the fast pain fibers. Now, the slow pain fibers tend to be a little bit more annoying because they're more persistent, because their job isn't just to tell you to remove a stimulus. Their job is to make you rest it, and ideally, if you can, do something about it. So that's like the pain of an MI, or the pain of like that finger where you can have both your fast and slow pain receptors stimulated. And that's usually what happens is something gets hurt, your brain is alerted to remove, is alerted so that you can remove yourself from it. And then after you remove it, it's still been injured and it still has to heal, and you still have to leave it alone. Extremes on either end are like bug bites and toothpick pokes will just hit fast pain fibers and they won't wake you from sleep. And then those things that just get slow pain fibers, like an acute MI, that's not about trying to remove yourself from the stimulus. You never see anybody swatting at their heart trying to get away from it. It's just like, oh, this really hurts. I need to rest and relax and stuff like that. A good example of both of them is if you get like something in your eye, or you get a splinter or a little piece of glass in the bottom of your foot. And I know that some of you have experienced this. Initially, your body, you trigger fast pain fibers, and you know that there's something there. Immediately, you want to get rid of it. You can localize it precisely, even if you can't see it. If something is in your foot, some little splinter, you know it's there. And then if it stays there and it starts to cause permanent tissue destruction, even if it's minuscule, if it's causing, persistent tissue destruction, your brain won't rest until you get rid of it. And that's whether it's your tooth or your eye or your foot. Almost all of you, I'll bet, at some time have had that experience where you become totally preoccupied with a splinter or a piece of glass in your foot. Even when everybody else says, I can't see it, there's nothing there, you know it's there and you won't rest until you get rid of it. That's the combination of both fast and slow pain. Fast pain fibers are helping you localize it so you know exactly where it is. Slow pain fibers keep you on it until something gets done about it. That's the difference between those two. And again, I tend to speak in extremes. It's usually never quite that clear cut. It's usually a combination of both things. All right, anyways, once this impulse gets transmitted to the brain by way of those neospinothalamic and paleospinothalamic pathways, then the next thing is perception, right? Pain is perceived in the brain. That's where those neural impulses are processed. Alterations in neural circuitry in the brain can cause changes in pain perception, and that's true. If you have some abnormality of the brain, like maybe you have an old injury or a tumor or any variety of things that can change normal alterations in circuitry, it can markedly change the way you perceive a pain experience. It's one of the reasons that sometimes people perceive things in a way markedly different than what we would expect. Also notice the last bullet point, the experience of pain is also influenced by psychosocial factors. If you're having a really great day, like some really amazing, awesome thing is happening to you, and you bang your elbow or bang your knee or one of those things that normally would really, really hurt. But if you're having a really great day, it's just not going to bother you as much. Conversely, if you're having a really, really bad day and just everything is going wrong and nothing is working right, like you go to the DMV and you didn't make an appointment and the line is 3 hours long and then you have to do something and then you finally get to the window and you find you don't have some piece of paper that you need and you just wasted this whole day and you still can't get registered or whatever, and then you go to get up from the table and you accidentally bang your knee on the thing, it's going to really hurt. It's going to hurt even more because you're having such a crappy day. That's an example of how psychosocial factors can influence the perception of pain. So perception can be altered by like physiologic changes in circuitry, like old scarring from an old injury that reroutes things, or those psychosocial things that we were just talking about. And then the other thing you have to consider with respect to the pain experience is that the brain actually modulates pain. The brain actually produces chemicals that can inhibit or attenuate the ascension of the pain signal to the brain, so your brain just doesn't feel it. These are messages, they're neurotransmitters that come down from the brain. They come down to the spinothalamic tract and basically try to interrupt the progression of those neospinothalamic and paleospinothalamic pathways. They're modulators because they don't typically completely block pain, unless you augment it with drugs, but they can make it more tolerable. And you do see people who just they handle pain differently. They appear to be much less distressed than others with the same stimulus, and those patients either just have endogenously awesome mechanisms for modulation, and then some people are really good with biofeedback. Like some people with chronic pain, and you have to have the right person who's both open to the intervention and capable of making it happen. But some people that have chronic pain really do learn to actually, by way of biofeedback, increase their own production of these neurotransmitters that block pain ascension. Here they are. It's a pretty picture, but it makes it harder to read. So if you look toward the top of the picture in the third ventricle, the periaqueductal gray, you see neurons coming down. And those neurons coming down are releasing two primary kinds of neurotransmitters. Enkephalins, that I'll circle right here. I just actually covered up the E in enkephalin, so I'm going to do it again. Get my little red pen. Enkephalins, God bless it, and serotonin. So hopefully I didn't mess it up enough that you can't see it. But you make enkephalins and serotonin. And these neurotransmitters come down from those areas of the brain. They actually move in a downward direction and block the ascension of those transmitted impulses from the paleospinothalamic and neospinothalamic pathways. That's endogenous pain suppression. It's your own body finding a way to block the ascension of pain into your head. Because you know what they say, the body only gives you what you can handle. So reportedly, if you're subjected to more pain than your brain can handle, your brain will modulate it by way of these enkephalin and serotonergic neurons. And some people just seem to be better at making them, period. You will see these people who just handle pain very well. And they tend to be the same kind of people who are just inordinately in a good mood all the time. And it's probably because they have an increase of neurons. I don't know if I mentioned this in another class. If I did, just skip this part. But a few years ago, I guess several years ago now, I was seeing a patient who had orbital cellulitis. She walked into the clinic with orbital cellulitis, and she had a fever, and her eye should have really hurt. Like, she should have been in a lot of pain. But she was really, she was just really smiley and happy and stuff. And as I was taking her history, she had this really convoluted history of all of these kind of weird pain syndromes and stuff. And it was just, I don't remember the details, but I had never seen anything quite like it. And she was telling me she was in Las Vegas on vacation. She was from the East Coast. I want to say somewhere in North Carolina or something like that. And she saw, when she was at home, her regular healthcare providers were a husband and wife physician team. And one of them, I think the husband was Western medicine and the wife was Eastern medicine. And she was telling me that, a lot of the strategies she used to manage pain were non-traditional Eastern medicine. And I said, yeah, I've really never seen anybody, who handled pain, you're just so sort of naturally happy. I said, you must have a really huge proportion of enkephalin and serotonin neurons in your brain. And she said, that's exactly what my doctor said. So I guess that was the Eastern philosophy spouse of the pair. But it's true, when you have a lot of enkephalins, you're just sort of happy. Some people refer to them as endorphins. Anyway, let's see. Okay, did we talk about this slide? Neurons in the periaqueductal gray and ventricular areas. Yep, they send their signals to the raphe magnus nucleus, and that transmits it down. Those the enkephalins and serotonins we were talking about. Analgesia signals can block the pain signals from arriving peripheral neurons. Yeah, these are endogenous analgesia, your enkephalins and your serotonin. They're natural pain blockers, and they're actually what we try to mimic when we give opiates. So, endogenous pain suppression. Endogenous pain, in other words, your naturally occurring enkephalins and serotonins, because of where they work in the brain, they block the ascension of pain from both type C and type A delta pain fibers. It makes sense if you think about what we've talked about. Both of those fibers bundle into the paleospinothalamic and neospinothalamic pathways to come up to the brain, and enkephalins and endorphins, or enkephalins and serotonin, are produced in the brain and work their way down. So of course they can block the ascension of pain from both of those pathways, so they can block the ascension of any type of pain. And I shouldn't say block, I should say attenuate, because like I said, your own natural endorphins never 100% block pain ascension. They just attenuate it to the point where it's supposed to be manageable, So endogenous pain suppression can inhibit the ascension of both pain impulses, both chemical, which stimulates type C fibers or slow pain, and mechanical thermal, which stimulates type A delta. Now, switching gears a little bit here, or maybe not, endogenous pain suppression. Let's see, I guess I should read your slide. Chemical stimuli excite type C fibers. Chemicals are released during the inflammatory response, which follows tissue injury. Pain is transmitted to, yeah, well, I already said that. Okay, and then the last slide here is just a reminder. So I guess these last few slides are, yeah, oh, summary. They're labeled summary. I should have read. So it was just, those last two slides were just a quick breakdown or review of type A delta fibers and type C fibers, and a reminder of the final thought that they both come up to the brain on their respective pathways, and endogenous pain suppression, which occurs in the brain, can attenuate the ascension of both of them. All right, so keeping in mind everything I just said in the last half hour, let's look at the pharmacology of pain management. Pharmacologic management of pain. All right, first class of drugs are the nonsteroidals. Nonsteroidal anti-inflammatory drugs, there's a ton of them. This list is not meant to be all-inclusive. It's meant to be representative. And NSAIDs, certainly you're familiar with them. They're available over the counter. They're available by prescription. There's one for all occasions. Like I said, there's a list a mile long. This is just representative. You'll notice that there are some asterisks here next to celecoxib. This is marketed as Celebrex, and this, I believe, is the only COX-2 inhibitor remaining on the market. So, well, what we mean by COX-2 inhibitor actually is coming up in the next few slides, so hold that thought. Almost all of them are both COX-1 and COX-2 inhibitors. Several years ago, there was sort of an effort in the pharmacologic community to try to come up with nonsteroidals that were selective for COX-2, because we thought, not we, I mean we, the collective healthcare environment, thought that COX-2 inhibitors would be equally effective but safer if they spared COX-1. The downside is then there seemed to be this association with increased cardiac events. I don't know that that's any different with the non-selective COX-1 and COX-2s, but those drugs had already been approved for a long time. The bottom line is some of the selective COX-2 inhibitors wound up getting yanked off the market because of that cardiac stuff, but it can happen with COX-1s too. So anyways, here's your list. There's a ton. I'm sure you're familiar with most of them. Ibuprofen, of course, this is like crack for arthritic pain. Etodolac, diclofenac, ketorolac, this is Toradol. Naproxen is naproxen. I mean, there's a ton of these out there. But the only one that's selective for COX-2 is celecoxib. All right, so mechanism of action. They covalently modify COX-1 and COX-2 pathways. Clears that right up, doesn't it? So there's these two pathways in the body, and we'll look at them in a second. Cyclooxygenase. COX is the abbreviation for cyclooxygenase. There's cyclooxygenase 1 pathways and cyclooxygenase 2 pathways. Cyclooxygenase 1 pathways are constitutive pathways, meaning they're always going on. They're just always happening. You see them all over the place. Blood vessel, stomach, and kidney are the examples that are given here. So cyclooxygenase 1 pathway, the COX-1 pathway, is a pathway by which you produce prostaglandins that do like day-to-day functions that we have to have. So they're always happening. They're constitutive. In blood vessels, there are prostaglandins that promote vasodilation. So we got to have that going on. There are, in the stomach, there are cyclooxygenase pathways that produce prostaglandin E2, which is the prostaglandin that you need to make the mucosal protective layer to protect your stomach from, what do you call it, the acid that you produce to digest food. So, in order to break down food for digestion, you have to be very acidic, but the acid would burn your own gut if you didn't have your mucosal bicarbonate layer in there. You need prostaglandin E2 to make that mucosal layer, and you need cyclooxygenase 1 pathway to get it done. So that's an important one. And then in the kidneys, cyclooxygenase 1 pathways are pathways that produce the prostaglandins that help assist with renal perfusion. One of the many factors involved in normal renal perfusion and filtration are renal prostaglandins, and they are produced by way of the COX-1 pathway. Now, COX-2 pathways are induced. They're not constitutive. COX-2 pathways are induced in the presence of products of tissue injury, and these are the things that trigger type C fibers. So I guess the easiest way probably to approach this is to say there's all different kinds of prostaglandins, and some of them are necessary for day-to-day function. Those that dilate blood vessels, those that help protect your stomach, and those that help perfuse your kidneys. And then there are the prostaglandins that trigger pain fibers, the type C fibers that carry the message of pain to your brain, and they're not necessary every day. In fact, we hope you never have them. But if you have tissue injury and that tissue needs to heal, then those prostaglandins will carry the message to your brain that you've got tissue injury. It'll trigger your type C fibers and say, hey, rest this area. So you see what's going on here? Almost all of our old-time COX inhibitors, cyclooxygenase inhibitors, also called non-steroidals. Remember, you always have to have 5 names for one thing, or referred to as anti-inflammatories. Our old-time, like ibuprofen, naproxen, even Toradol, Lodine, all those ones, they block both COX-1 and COX-2 pathways. So yes, they help control pain. They decrease the synthesis of prostaglandins that trigger those type C fibers, but they also decrease the synthesis of prostaglandins that help promote vasodilation, that help protect your stomach, and help protect your kidneys. That's where their side effects come from. So yes, their effect is that they reduce pain by reducing the prostaglandins that trigger type C fibers, but they also can reduce vasodilation, so they can cause vasoconstriction and water retention, thus increasing your risk of a cardiac event, especially if you already got a cardiac history. They decrease the synthesis of prostaglandins in your stomach, and that's why some people get ulcers. And they decrease the synthesis of prostaglandins that help maintain renal perfusion, which is why people who already have renal dysfunction absolutely can't take them. It can put them into renal failure. Believe me, I've done it. Take it from the voice of experience. You can put somebody into straight up iatrogenic renal failure by giving them Motrin, because I've done it. Thankfully, when you stop giving it to them, often, the renal function will recover. But you just don't even want to go there. Just remember, renal dysfunction, stay away from the non-steroidals. It's like #1 patient teaching education. Okay, what else we got here? Oh, okay, so here's your COX pathways, right? So this is like everything I just said. This is like everything I just said. So you see your COX-1 pathway, kidney, stomach. I must have seen this diagram first. And then your COX-2 pathway is your inducibles. This is the one that triggers your type C fibers, so you get the idea. Most non-steroidals will block both of them. We put a big red X right in front of both of them. So if you give like ibuprofen, you'll block it all. Now keeping in mind, for every bodily function, there's 15 ways to get it done. So if you're otherwise healthy and you pop a few Motrins for your migraine or your arthritis or your broken finger, you're not going to shut down your kidneys, put yourself into hypertensive crisis, and give yourself ulcers. There are so many other mechanisms that will kick in to compensate. But what you do want to keep in mind is if you use them excessively for the long haul, you increase the risk of these problems. If the patient already has a tendency toward one of those problems, long-term use of nonsteroidals can exacerbate it. Like if you're already hypertensive, your patient should probably not be living on Motrin for arthritis. Or if they have had ulcers in the past, then they're especially vulnerable to ulcer formation. So try to stay away from the long-term non-steroidal use. And if they already have some loss of renal function, stay away from the non-steroidals. Right? That's why, like I said, I don't know, 15 years ago or so, there was a real effort in the pharmacology world to find cyclooxygenase inhibitors that were selective for COX-2. The hope was to spare the COX-1 and just inhibit the COX-2. So you could see how awesome that would be, because then it would only block the stimuli for pain. And we had a few drugs right off the bat. And I can't even believe, I can't remember the names. I mean, Celebrex is still out there. There was another one that was really more, Vioxx. Yeah, I think that was the name of it, Vioxx. That got to be more famous. Celebrex was first on the market, but Vioxx had really awesome marketing, and it was used very aggressively, and then you started to see these cardiac events. So the reason probably for all of the cardiac events is that people who put their patients on Vioxx or any COX-2 selective, those patients probably already had underlying health problems to start with, and then they got put on a bunch of nonsteroidals. And even though the drugs were COX-2 selective, they weren't 100% COX-2 selective. They were just better. I think mostly they spared the stomach, if I remember correctly. They spared the prostaglandin E of the stomach. But there was still a potential for vasoconstriction and leading to hypertension. And apparently it happened because there was enough cardiac events to get the thing, taken off the market, or voluntarily withdrawn or something. But anyways, so that's the story with nonsteroidals. Now, my real takeaway message for you is where they work. They don't work in the brain. They have nothing to do with that enkephalin and endorphin phenomenon. COX inhibitors, whether it's COX-1 and 2 or COX-2 selective, their mechanism of action is to decrease the synthesis of prostaglandins that stimulate type C fibers. So what that tells you is they're only going to be effective for inflammatory pain, for pain that is produced when there is tissue destruction and products of inflammation, right? They're not going to be effective for other types of pain like neuropathic pain, which we'll talk about in a few minutes. If your pain medication works by blocking the synthesis of prostaglandins, then it makes perfect sense that the only pain they're going to prevent or treat is pain that is triggered by prostaglandins binding to type C fibers. All right. So yeah, the indications for them are inflammatory pain, basically. They're great for musculoskeletal pain. Like I said, these things are like crack for arthritis because that is inflammatory pain. In terms of side effects, they all relate to this business of the other effects of COX-1 inhibitors. And there's all sorts of prostaglandin-mediated functions all over the body. Prostaglandins are also responsible for causing uterine contraction in labor, right? So if you want to stimulate labor, one of the more more conservative mechanisms to inducing labor is to insert like a prostaglandin capsule or something. I'm not an OB person, so I don't know for sure, but I believe they do vaginal insert of some prostaglandin thing. I do know that the medical management of induced abortion is a prostaglandin cousin. And I want to say, like before probably going far afield here because this isn't my area of expertise, but I think before using some of those like the tubal blockers like Essure or those kind of procedures to ensure that the uterus is empty, patients are given a strong dose of prostaglandin to enforce uterine contraction and make sure the uterus is empty. So anyways, I could be a little bit wrong on some of those points, but I can tell you to a certainty that prostaglandins will produce uterine contraction, and prostaglandin inhibitors like nonsteroidals will inhibit uterine contraction. So don't take them when you're pregnant. Drug interactions potentiate anticoagulation because of the prostaglandin synthesis piece on platelets, increases lithium and methotrexate toxicity, really will increase the toxicity of pretty much anything that has a narrow therapeutic window because they can alter renal function. They can decrease renal function, so decrease renal excretion, which is why any drug that has a narrow therapeutic range, you have to be really careful when you add nonsteroidals. And because they decrease renal function, you have to monitor for hyperkalemia because, again, the normal range of potassium in serum is so low, like 3.5 to 5, that it doesn't take very much to crank you up to an unhealthy level of potassium. Impaired renal function, which can be exacerbated by nonsteroidals, can do it. Now, I can't leave the topic of anti-inflammatories without talking about acetaminophen, because acetaminophen does come under this heading. I know sometimes you can get into these great philosophical debates about is acetaminophen an anti-inflammatory or isn't it? I mean, I don't know. Call it whatever you want. I can tell you how it works, and then somebody who's a lot smarter than I am can decide if it's truly anti-inflammatory or not. Acetaminophen also inhibits cyclooxygenase. And there is some debate in the learned population. Some people call it a COX-3 inhibitor, and others suggest it is highly selective for COX-2. Like I said, I don't really care. I just know that it works for some things and it works better for some and not as well for others. Whether there is a COX-3 or whether it's just highly selective for COX-2, I don't really care. It is a cyclooxygenase inhibitor, though. So whether you consider it a highly selective COX-2 or a COX-3, the important takeaway is it's going to work in the same general way that nonsteroidals do. It's not identical. It tends to be safer on the kidney, so obviously it doesn't have as much impact on renal prostaglandins. It doesn't have the same vasodilation or antiplatelet properties as a nonsteroidal, so it's not going to have the same impact on the, the blood vessel ones, and it's not linked to ulcer formation like nonsteroidals are, so it's not going to have the impact on the stomach prostaglandin. So either it is very highly selective COX-2, or it's got its own cyclooxygenase. It's got its own COX that it targets. I don't know. So this diagram shows it as COX-3. I guess the takeaway messages from my perspective on this discussion are for you to keep in mind that it does work in general in like the same area, the same place in physiology as nonsteroidals, which is at the level of transduction, right? It works to help prevent the transduction of a stimulus to a neural impulse. So it doesn't work in the brain. It's only going to work out in the periphery. It's only likely to help with inflammatory pain. It also helps with the reduction of fever, like ibuprofen does, but I don't know what your experiences are. Subjectively, I just find it not to be as effective as the nonsteroidals for any of these things, fever reduction, pain reduction, or whatever, which is fine because not everybody needs the biggest gun. Like most everything else, it's not as effective as other options, but it tends to be safer than other options. So, if you have somebody who really needs anti-inflammatory, but they do have ulcers, and they just can't take nonsteroidals, or they have renal dysfunction, their GFR is like 40, and you can't give them nonsteroidals, give them acetaminophen. It may not have the same utility for pain reduction, but it'll have some, and at least it's going to be safer. That's the take-home message as far as I'm concerned. Now, next we've got the opiates. All right, opiates are totally different. Opiates, big topic of conversation now because everybody's like, oh, don't give opiates. It's a shame. I mean, yes, the CDC has published this position on opiate management, and we have to adhere to that because that is our national guideline for care now. I just, encourage everybody. I mean, I'm not encouraging everybody to freely prescribe opiates, but I do encourage you to remember that the pendulum often swings too far in one direction or the other. It's what happens. Something happens, and then all of a sudden, we never do this again for the masses, and it feels like that's the way it is for pain now. Of course, opiates have been overused. I'm not suggesting they're not. I've practiced long enough. I mean, I've heard every story. I've heard every story about accidentally flushed them down the toilet and they expired, or nothing else works for me, or whatever. All the stories that if you haven't heard them yet, you will if you hang around this gig long enough. Yes, there's definitely lots of opiate abuse out there, but there are also people who need it. So I guess I'd encourage all of us, myself and you, to just try to remember that the default position for pain management shouldn't necessarily be no opiates for you. The default position should be, let's make an assessment to see if you really need it or not. And it is very true that if somebody needs to be on opiates long term, they absolutely should see pain management. So, if somebody comes to you with what clearly is like a bad sprain or a break or, I don't know, like a big fish hook through their hand or something, it's totally reasonable to give them 5 days worth of opiates. They're not going to become addicted. They're not going to, chances are they're going to be totally fine. But if somebody comes to you and says, oh yeah, I've been taking OxyContin for the last 5 years because of my car accident, it's not for us to continue that without sending the patient to pain management, because pain managements are the specialist. And sometimes they will make an assessment and say, yes, you know what, for this patient, their pain isn't amenable to other interventions. The appropriate thing to do is long-term opiate management. I endorse that. And then when they come back to you, if you're comfortable with it, you can certainly continue that. If you're not comfortable with it, you just say, I can't do this, go to pain management or go to somebody else. I'll tell you a little story. This just happened very recently. I had this one patient who, and I know you've heard me say I work in a very rural area. So my patients To go to a pain management consult, they have to drive a little over 50 miles one way, and often their copay and stuff is higher. So I really do. If I will send them to pain management once, and if pain management says, I agree, this strategy in this patient is very appropriate, continue whatever their Lortabs for the rest of their life. If I have it in writing from pain management, and I'm comfortable that the patient is not like selling or anything, I'll go ahead and continue it. So I had this one patient who came to me with like every classic story about that you get from drug seekers. And I was like, no, you got to go to pain management, tell them your story and then we'll see what they say. And then he came back to me and he's like, oh, I can't get in, like all the usual stuff. I couldn't get an appointment. They said they couldn't see me till February. What am I going to do? I said, I can't help you. You got to wait. Then the next thing I know, he makes an appointment and comes back and he's like, yeah, pain management said I should just come back to you for my prescription. And I'm like, really? Because I didn't get a report from pain management. Who did you see? And he's like, I don't know. I don't remember, like some guy, and he was a real jerk, and I don't remember where his office was. These are all usually cues to, story, like drug abuse kind of story. And so I said, I can't do it. I need to see this report from pain management. Well, when I finally tracked it down, he really had gone. He had had MRIs and a good evaluation, and the pain management consult was really a detailed one. And it was a pain MD, and he said, yes, this is the story. The patient has seen X other people. I have reviewed the records. I do not believe that surgical options are viable for him. We tried injection therapy without success. My advice is to return to primary care, for long-term management. I was like stunned. I was stunned, but once I had the pain management consult, I had to back it up and go, you know what? Everybody deserves the benefit of the doubt, I guess. So what I'm telling you is I still didn't like it, but I felt more compelled to follow the plan of care as derived by a specialist, just like I've sent patients to cardiologists and gotten a plan of care, or pulmonology, and I might not always understand why they're doing what they're doing, but it certainly carries a little more weight in terms of prescribing. I don't know how I got off on that tangent. I guess about opiates. It's an anti-opiate world. And we definitely needed to tone it down, but just do keep in mind that some people really do need the stuff. All right, I guess I should stop digging my own hole here. Let's go back to the slide. Opiates, mechanism of action. All right, so this is totally different than nonsteroidals because opiates mimic what natural enkephalins and serotonins would do. They work from the brain down. And their mechanism of action is that they bind to mu receptors. There are mu receptors all over the body, including the brain. And the brain is where the enkephalins and serotonins that are made in that periaqueductal gray and third ventricle come down to attenuate ascension from the spinal cord. So these bind to mu receptors, effective in the management of pain caused by stimulation of pretty much all free pain, free nerve endings that are transmitted over intact neural pathways. The bottom line is that these inhibit the ascension of pain at both the spinal cord and, going up through the, pons and medulla. How do we know this? Oh, I guess back in the day, like, before there were IRBs and stuff and protective boards, these were tested on dogs. And they would like instill morphine into the third ventricles of dogs and then apply pain stimuli peripherally and assess how it ascended. That was back in the early days of how opiates were first studied. Anyway, they work from the brain down. So that should give you an idea about how they manage pain differently than the anti-inflammatories do. So because opiates do work in the brain and they can have like serious side effects like depressing respiratory centers of the brain, many years ago, and this totally predates me by decades, somebody came up with the approach that if you gave an opiate agonist-antagonist in combination, it could help attenuate the dangerous side effects and it would be a safer approach to opiate management. And there were 3 combination agents that were widely used: Talwin, NuBane, and butorphanol used to be marketed as Stadol. It was Talwin, NuBane, and Stadol. NuBane is available as an inhaled form, and if I remember right, that was used for migraine management. But those were the three agonist-antagonist combinations, and like I said, they were originally marketed to help reduce unsafe side effects. I think it just didn't work. I mean, I think it turned out not to really have the desired effect. So, new generations were never formed, and, they do remain another option. I mean, I think some of them have little niches, like NuBane is available for inhalation. Oh, I can see why nobody would want to market that today. But butorphanol, from what I understand, is particularly safe in pregnancy and labor, and is still used for the management of pain in labor when opiates are required. But the newer one here is called Embeda, and this is a morphine-naltrexone combination. This is a 21st century agonist-antagonist combination. This was marketed like after the year 2000, and the point of this one was to try to decrease abuse. So it's sort of like an M&M, you have morphine on the outside and naltrexone on the inside. And the way it's designed for release, this is my understanding, I've never prescribed it, never even seen it used, but my understanding was that if you took it properly, the morphine would do its thing, and then after it was metabolized and excreted, then naltrexone was on board, but that the naltrexone wouldn't have a serum level until after the morphine had done its thing or something. I don't really fully understand it, but the idea was to try to help prevent abuse. This was shortly after the whole OxyContin, debacle, where OxyContin, which was meant for long-term use, and then people were crushing it and snorting it and stuff like that and abusing it and then dying. And Embeda was meant to be a long-acting opiate that could not be abused, I guess. But it didn't turn out that way. Somebody figured out how to abuse it, and it never really caught on. I mean, I think it's still available, but I've never actually seen it used. Even I've never seen pain management use it. No offense to the Embeda people, but I've just, never seen it. Kind of an interesting commentary on the times. The opiate agonist-antagonist combinations of like the 30s, 40s, and 50s were designed to help be safer for people, whereas the one of the 21st century was to try to thwart abusers. So anyways, most opiates that are available now are just opiates. We do have some combination agents that are not combination with an antagonist, but they're combination with other mechanisms of pain management to try to get at pain from multiple modalities. But most opiates are just opiates. And the way they work is by binding mu receptors in those descending pathways in the brain and spinal cord and trying to attenuate the ascension of pain, which is great, and they do. Opiates are great for pain management in most people. The problem is the unintended effects. They do depress the cough center in the medulla, which is fine if you're having a problem with cough, which is why the most effective cough medicines have an opiate in it. But if you're not coughing, and we suppress your cough centers, then it really does suppress a protective mechanism. And especially in somebody post-op or somebody who's like a little out of it, that can really be safe. That can precipitate aspiration. Also, opiates can stimulate the chemoreceptor trigger zone. The chemoreceptor trigger zone, remember, is that place where you process stimuli for nausea and vomiting. So opiates can make you feel like you want to vomit, or even some people just barf their brains out when they take this stuff. Notice there's a bullet point here: nausea and vomiting rarely occur in recumbent patients, suggesting that there is a vestibular component, the inner ear, that there is a component in terms of balance and sensation combined with stimulating the chemoreceptor trigger zone that can exacerbate nausea. So people who are bedridden, maybe post-operatively, or people who are like end-stage cancer and they're bedridden, don't tend to get as nauseous with this stuff. So, okay, we said they bind mu receptors, and in the descending pathways of the brain, that's desirable. But the problem is, any synthetic drug is never as precise as the natural mechanism that we're trying to inhibit. So what happens with the opiates is that you bind a lot of other mu receptors that are spread all over the body, and this is what you can get out of it. That's not the way I want to say it. These are the adverse effects that can arise. So there's a lot of mu2 receptors in the GI tract. When you give an opiate, and bind Mu2 receptors. These are some of the things that happen. Decrease hydrochloric acid secretion in the stomach, so you can't break down food as well. So digestion is impaired. Decreased biliary, pancreatic, and intestinal secretion. So again, those enzymes that facilitate digestion are impaired. Enhancement of non-propulsive contractions in the small intestine. So you're increasing the contractions that don't do you any good, that are just causing pain. This is like colically intestinal pain. At the same time, it inhibits propulsive contractions. So it's harder to actually move GI contents forward. So now, like if you eat, you can't digest it as well. You can't move it toward the other end as well. At the same time, you have enhanced non-propulsive contractions. So your pain is enhanced and your functionality is decreased. And then, to add insult to injury, at the very bottom here, augments tone of the anal sphincter. Just tightens that up a little bit. So when you finally get this poorly digested food bolus, when you finally get it to the other end, you know, amidst lots of pain because you're enhancing your non-propulsive contractions, you finally get your stool down to your anus and augments tone of the anal sphincter, so it makes it harder to get out, which is why opiate-induced constipation is such a big deal. It's a huge problem. There are several medications now that are designed specifically for opiate-induced constipation. They're like dynamite. Action on the pain-free adult. I guess these would be the patients that abuse them. I don't know why else you would take an opiate, except with cough. So they can promote drowsiness, nausea, vomiting, because the pain-free adult is usually moving around. Just a general sense of apathy. No significant effects on healthy hearts, but notice in cardiac disease, 8 to 15 milligrams of morphine decreases oxygen consumption and myocardial workload. Now, this isn't, it's a little misleading because, excuse me, there is a role for morphine use in patients having an acute MI, and for that matter, acute congestive heart failure. Morphine is kind of different from any other opiate in that it has not just a pain inhibiting component by blocking mu receptors in the brain and spinal cord, but it also is an anti-anxiety agent. Pain and anxiety are two different things physiologically, and most opiates only address pain, not anxiety. But morphine has an effect on the anxiety areas of the brain too. It can reduce it, and unlike other opiates, morphine decreases myocardial oxygen consumption and myocardial workload, and that's actually a big deal in somebody who's having an acute MI, and for somebody in acute congestive heart failure for that matter. So very appropriate and helpful for many reasons to give morphine to people having an MI. It's not just about pain reduction, it's about reducing workload of the heart as well. And in patients with like acute pulmonary edema, you don't see opiates used as commonly now just because it is, you know, an anti-opiate world. But when you give morphine to a patient in acute pulmonary edema, not only does it decrease their anxiety, but it also venodilates and distributes some of that blood volume out into peripheral circulation and decreases the workload of the heart, and at the same time decreases myocardial O2 consumption. There was a time when morphine was among the first line drugs you gave to people in CHF, right up there with Lasix. And you just don't do it anymore because it is an anti-opiate world. So the side effects are all related to the things that it does. No big surprise here. Now, I got a couple specifics, couple oddball ones here. Nucynta and Nucynta ER. Not sure if you're familiar with these. These also never caught on quite the way I think they had hoped to. Nucynta it's considered an opiate. It is a synthetic mu receptor agonist. So it agonizes mu receptors just like morphine does, but it also has a component in it that is a norepinephrine reuptake inhibitor. So when we talk about neuropathic pain, which I suspect we will at some point here, when we talk about neuropathic pain, you'll see the role of norepinephrine reuptake inhibition. So Nucynta was designed as an opiate to capitalize on another mechanism of pain management to try to allow for the fact that if you have two mechanisms in one pill, you can decrease the amount of the opiate. Nucynta is considered kind of a designer drug. It's a newer one. It's a synthetic one. And there are both short and long-acting forms. And it does have an indication for diabetic peripheral neuropathy, and because of that norepinephrine piece. But it really can be used for any any pain that you would use an opiate for. And I have seen pain management use this one successfully. Tramadol is old school. This is marketed as Ultram. This is a very selective mu opioid receptor. It was originally marketed actually as a non-addictive alternative pain medication, but it turned out that it can produce a physical addiction. There's really no great advantage to using this. It does have, in addition to the weak mu opioid receptor agonist property, a norepinephrine reuptake piece. Just overall, I believe not as efficacious as Nucynta. It also potentiates serotonin release, which remember is the other neurotransmitter that helps block the ascension of a pain impulse. And serotonin in other areas of your brain helps improve mood. But this drug's original claim to fame was it cannot produce physical addiction, and now we know that it can. And the other thing is that it lowers the seizure threshold, so it can increase the risk of seizure, especially in people that have any other risk like other drugs of abuse or a whole old head injury or something like that. So Ultram is really becoming less and less popular in the pain management world. In fact, the pain management consultant that I refer patients to doesn't use Ultram anymore, tells the patient they will not prescribe Ultram because of this significantly higher risk of seizure. I actually had a patient come to me and she's like, she's on morphine or some other heavy duty thing, and she said, can you prescribe my Ultram? My pain doctor says he can't. And I said, well, he's prescribing morphine, but he won't prescribe Ultram. And she's like, I don't know. That's what he said. He said he can't prescribe the Ultram, which sounded absurd to me. So I I know the practice. So I called and I said, can you tell me what this is all about? Like, your patient is asking me for Ultram. I don't understand why you can't prescribe it. And he's like, it's not that I can't prescribe it. It's that I won't prescribe it because there has been such a marked increase of seizure complication, and it just isn't offset by the potential utility. So I tell my patients I will not prescribe it. And I said, okay, so you're telling them you don't want them to have it from anywhere. Like, you don't want me to give this to her. And he's like, no. So that was it. I mean, that was the first I had heard of it. So after I heard that, I started looking into it and found that it was indeed true. Just a risk benefit thing. And there's no great benefit to it. And the risks are too high. So, why bother? Hysingla is a long-acting hydrocodone. This was an ER is extended release. This was a great idea when it first came out. There's a lot of people in the world that are on long-term hydrocodone management, like 4 times a day, because prior to October of 2015, this was a Schedule III drug, not a Schedule II. So it was an effective opiate that was a lot easier to prescribe than a Schedule II. There weren't the restrictions on refills and stuff like that. So a lot of people were on it for the long term. Then in October of 2015, recognizing the potential for abuse, the DEA rescheduled it as Schedule II. So, we just pay more. It's different now. There's more attention to it. So because there's all these people on chronic short-acting hydrocodone, this Hysingla ER was a great idea. Not only is it an abuse deterrent, and you can read all the reasons why it is, but in the world of pain management, if somebody needs to be on an opiate for the long haul, we really do prefer that it is a sustained release, long-acting opiate for a lot of reasons. The most compelling one really is that there's like the post-dose euphoria that makes you high when you take an opiate, and then there's the pain control achieved by activation of mu receptors. Post-dose euphoria, so if you're taking this stuff 4 times a day, you're getting 4 shots of post-dose euphoria, and even if you aren't trying to abuse it, you can't help but notice that you feel good. I mean, I've had a lot of people over the years say, yeah, like I can kind of see why people abuse this stuff. If you're only taking it once a day, that really cuts down on post-dose euphoria. The other obvious piece is that if you take a long-acting once-a-day dose, you have a more consistent around-the-clock pain control. You're not going up and down and up and down. The half-life is longer, so you get a more steady state pain relief. So in the world of pain control, when people need to be on an opiate for the long haul, we prefer that they be on a long-acting one, and Hysingla is the first long-acting hydrocodone that's out there. There's lots of long-acting morphines and long-acting Dilaudid, and there's Duragesic and stuff like that, and people do respond differently to different pain drugs. I've had several patients tell me that they can't take morphine, they don't want OxyContin, and you would think intuitively that they would because they're more potent, but they don't. There's lots of different nuances in the metabolism of opiates, and some people do better with hydrocodone, so it was really awesome to have this long-acting one released. In practice, it just hasn't worked because I have not found an insurance company that will cover it without having you surrender your firstborn child, basically. I mean, the steps that you have to go through to get this stuff covered, like they want you to try everything else under the sun first and all other combinations. I have one poor soul who really does need his pain management, and he doesn't want to take pills 4 times a day, but he cannot take morphine. He just doesn't find the level of pain control with OxyContin. We even tried Duragesic patches, and it just didn't work. It wasn't that he didn't like it was too much. It just didn't work as effectively as hydrocodone. There is obviously some nuance in the metabolism of these drugs that are different, but the insurance company just wouldn't cover the Hysingla unless he went through all of these escalating stages. It was just absurd, and he finally gave up. So in theory, it's a great idea to have a long-acting hydrocodone, and for sure, if you're working with a patient who you are acknowledging, perhaps you have a pain management consult and you acknowledge that they're going to have to be on an opiate for the long haul, you want to get them on a long-acting one as soon as you can. It gives you better consistency of pain control and less potential for abuse. All right. Last things here are the antidepressants and anti-epileptics. So they both help with the neuropathic aspect of pain. And it has a couple of different implications. Some pain is neuropathic in origin. The most obvious one is diabetic peripheral neuropathy. Another obvious one are the long-term consequences of herpes zoster, shingles. There is pain that originates as neuropathic in origin, and the most effective pain management are going to be drugs that have their action on the neuron, on the nociceptor. Then the other thing is that the pain centers in the brain are also right around there in that area of the reticular formation in the pons. And that happens to be the action also where most of our antidepressants work, specifically those that have an impact on norepinephrine reuptake. So antidepressants can work for a few mechanisms. Of course, your handout says the mechanism of action is not well defined, and that's true. The things that I'm telling you are what's theorized. Centers of the brain in which pain is perceived are very close anatomically to those in which mood responds to changes in neurotransmitter concentration. So we expect logically that the two are sort of intertwined. Not to mention the fact that people who are in chronic pain are often depressed, and people who are depressed experience pain more acutely. So it's not a big surprise that there's some crossover here. The antidepressants that are most effectively used for pain management are the SNRIs, the serotonin norepinephrine reuptake inhibitors, and the tricyclic antidepressants. And the thing they share is that they both have an impact on the norepinephrine reuptake piece. Serotonin, interestingly, doesn't have the impact on pain control. And it's interesting because serotonin is one of the neurons up in the periaqueductal gray that helps block the ascension of pain, but that's not where these drugs concentrate. And so it's the norepinephrine piece of these two classes of medications that help control pain best. SSRIs have been trialed for pain control, they're just not effective. Now the anti-epileptics, these also, chemically they're very similar, or structurally they're very similar. Structurally, they are very similar to the tricyclic antidepressants. They are believed to potentiate GABA. Remember that GABA is the primary inhibitory neurotransmitter of the brain, and glutamate is the primary excitatory neurotransmitter of the brain. So these anti-epileptics they are believed to reduce the pain experience, to reduce perception by potentiating GABA or inhibiting glutamate. There's also some discussion that they are believed to stabilize the nociceptor, and decrease the excitation down there at the level of transduction. Because one of the theorized mechanisms of neuropathic pain is that the actual free nerve ending has become destabilized. It's altered in shape and altered in form, and the membrane ends are changed, and they are more susceptible to pain triggers, and that this can stabilize that. So the anti-epileptics and the tricyclic antidepressants and the SNRIs, their primary impact on pain is that there's some ill-defined mechanism in the brain where they either potentiate GABA, inhibit glutamate, and stabilize more peripherally those pain-receiving nociceptors at the point of transduction. That's why they're most useful for neuropathic pain. I mean, their utility in neuropathic pain is very clear. Like diabetic peripheral neuropathy and the pain of shingles. The other thing, though, is that lost my train of thought. Oh, any case of chronic pain, there's believed to be a neuropathic component. The theory is that if you are subjected to the pain experience for a projected period of time, of course there's going to be structural changes in the nociceptors, so of course they're going to have a heightened sensitivity to stimuli. And so anybody who's got chronic pain, especially poorly managed chronic pain, they're likely to develop that neuropathic piece. And that's why chronic pain, even if it wasn't neuropathic in origin, even if it wasn't like, say, diabetic peripheral neuropathy, almost everybody who's on chronic pain management needs to be trialed on an anti-epileptic or an antidepressant to see if you can decrease the use of opiates or even non-steroidals. Pregabalin is Lyrica, right? And Lyrica is one of the more popular ones for neuropathic pain, again, if the insurer will pay for it, because it doesn't have quite the side effect profile that some of the other anti-epileptics do. Several anti-epileptics are effective for pain management. Neurontin is a really popular one. Back in the old days, Tegretol, carbamazepine was very commonly used. Even Dilantin is used for chronic pain management. And then lots of anti-epileptics, well, not lots, but a few are used specifically for migraine pain, like Topamax. So they all definitely have this potential, but pregabalin is the one that seems to be more side effect free, and pregabalin actually has a little bit of a plus side in that it can improve like social anxieties and things like that. So pregabalin is a popular choice, again, if the insurance company will pay for it, excuse me. More often the insurance company won't until you try older ones like Neurontin. You will often see Neurontin as a first go-to drug for neuropathic pain. So again, hopefully in your clinical courses, you'll get a lot more information about the actual application of these things. It's my hope that you understand better how they work. So when you look here at this little selection of an agent algorithm, here's the thing. Acute pain, like I broke my ankle, I have a penetrating foreign body, or or I sprained my ankle. With acute pain, what you're primarily dealing with is inflammation. And so for moderate acute pain, the drug of choice is an anti-inflammatory. For a sprained ankle, high-dose Motrin, injectable Toradol, and then oral Toradol for 5 days. That's your number one choice. If that's not cutting it, you certainly can use an opiate short term, because everybody really does experience pain differently, and what you or I might think could be handled by Motrin, somebody else really might need a lower potency opiate to get through a few days. You're really not likely to create an addict for short term for acute pain. If the acute pain presents as severe, if we're talking about a femur fracture, right? Then you're going to start, like, oh, let's take some Motrin and see what happens. You're going to start off with the opiate, augment it with a nonsteroidal, because nonsteroidal does help that inflammatory component. The opiates and the nonsteroidal work on two different pathways, so even in severe pain, the addition of an anti-inflammatory can perhaps reduce the amount of the opiate that you need to use. And that's why so many opiates come in combination agents, right? Like you have Percocet, which is oxycodone along with acetaminophen. You have Lortabs and Lorcet, which is the same thing, hydrocodone with either an aspirin component or a acetaminophen component. Excuse me. chronic pain is a little bit different. If a patient presents with chronic pain, it depends on the nature of the pain. If it's chronic visceral pain, like a patient with cancer pain, they're really most effectively managed with an opiate. You don't want to make the patient suffer over this. Give an opiate, augment it with a nonsteroidal for the same reasons that we discussed. If the chronic pain presents as neuropathic, like diabetic peripheral neuropathy, you start with an anti-epileptic drug like Neurontin, and if that doesn't give them optimal pain control, then you add an SNRI or a TCA, depending on patients' risk factors and what's available to them. Because in neuropathic pain, you really want to try to maximize your ability to stabilize the neuron and to decrease the perception up there in that area of the brain. If they present with chronic musculoskeletal pain, this is chronic inflammatory pain, you start out with a nonsteroidal, and if you don't get optimal pain control, try treating the neuropathic piece that usually presents with chronic pain, right? So you will see people with like really bad long-term arthritis on daily nonsteroidals and a daily anti-epileptic drug. If it's chronic and non-malignant pain, you really want to avoid the addition of an opiate if you can help it. Now, every one of these has another step. Like every step of the chronic pathway has another step, and that's add whatever we didn't already add. So if you have chronic visceral pain and you're maxing out the opiates and they're on nonsteroidals and they're still in pain, and when I say maxing opiates with cancer pain, I mean you get to the point where you're worried about respiratory suppression, add an anti-epileptic and see what happens. They may have developed a chronic piece. For the chronic neuropathic pain, if you max them out on their neurologic options and they're still having pain, you need to add an opiate. You need to block that pain up there at the ascension in the same way that enkephalins would. And if they have chronic musculoskeletal pain that you're not getting good pain control with the nonsteroidal and the anti-epileptic, then you need to go ahead and add the opiate. Now again, in these chronic circumstances, if they have chronic neuropathic pain or chronic musculoskeletal pain and you've maxed them out on these choices and they're still not in good shape, really in the right world, you'll send them to a pain specialist who then will probably endorse an opiate plan of care, and then you feel better about doing it. Or they may have some other options in the world of anti-epileptic drugs, some things that you hadn't thought about. So when you get to that place, it's really best to get a pain consult if you can. Sometimes you can't, and then it's just appropriate to add an opiate. So again, this is a guideline. It's not a shackle. I'm sure that there's lots of other ways to take off in lateral directions from this, but this is a pretty good place to start just based on the mechanisms of these different agents. Neuropathic pain is not likely to respond to anti-inflammatories because inflammation isn't the mechanism of pain. On the other hand, other chronic forms of pain probably will respond at least in part to an anti-epileptic or an antidepressant because most chronic pain does have a neuropathic component. Musculoskeletal pain, if the patient can tolerate the long-term nonsteroidals, does usually respond pretty well to nonsteroidals because it is usually inflammatory. So that's all I know. It's just always about understanding how they work, picking the best of those provided, doing your risk-benefit analysis, doing the best you can. And if that doesn't work, send them to pain management because that's what specialists are for. So, well, that took longer than I thought, but that's all I got. So I hope it was helpful, and I'll see you next week.